Hello, my name is Niklas Jonsson. I'm an anesthesiologist and intensivist at Karolinska University Hospital in Stockholm. I'm going to talk about sepsis-associated AKI. There has been a paradigm shift in the view of sepsis-associated AKI. We now think it's about the microcirculation, not the macrocirculation. And we think that the tubular cells adapt and they don't die. Also, we believe that damps, PAMPs, and inflammation are crucial. I'll tell you more about that. Historically, the hypothesis was that when the patient was in septic shock, the renal blood flow decreased, which caused a tubular cell ischemia and acute tubular necrosis. So the treatment was to improve cardiac output and improve renal blood flow. We used to give dopamine and we used to give fluid boluses. Now we know that didn't work. The hypothesis now is that the renal blood flow is unchanged or increased in septic shock and that the tubular cells don't die, they adapt to survive. We believe that sepsis-associated AKI is an inflammatory disease of the renal microcirculation. These are the questions I'll try to answer today. How can sepsis-associated AKI occur without previous shock? And why is GFR reduced when cardiac output is okay? And how can we protect the kidneys from AKI in sepsis? To answer the first question, I'll have to tell you about some recent advances in knowledge. In epidemiology, experimental studies, in vitro studies, and post-mortem studies. AKI has been shown to be prevalent even in populations without septic shock and without hypotension, like in populations with pneumonia. Here in the graphs we see a non-severe sepsis subgroup and a non-ICU subgroup that still had a high incidence of AKI. In this particular study, they show that acute kidney injury in non-severe pneumonia was associated with an increased immune response and a lower survival. Another study showed that hypotension per se was not independently associated with sepsis-associated AKI. Experimental studies have also proven the old hypothesis wrong. This is a study from Rinaldo Bellomo's group in Melbourne, where they induced sepsis in sheep, which resulted in AKI, but unchanged or increased renal blood flow was seen when they measured it directly. Another study from Karolinska showed that sepsis induced in sheep caused renal dysfunction, and the renal dysfunction could be reversed by toll-like receptor 4 inhibitors. Histologically, they saw a reduced renal neutrophil infiltration, attenuated endothelial swelling, and they didn't see any significant tubular damage. Also, in vitro studies are consistent with the new hypothesis. In this study, AKI-like changes were induced by pouring plasma from septic patients over cultured tubular cells and podocytes. They could see alterations of polarity in the tubular cells. There was reduced expression of the tight junction protein ZO1, and the podocytes showed increased permeability to albumin. There was reduced expression of megalin. Megalin is the protein responsible for reabsorption of albumin, cystatin C, and other proteins from the urine. This image shows firstly the normal appearance of expression of tight junction protein ZO1. The middle image shows what happens when you pour normal plasma over the cultured cells, and the last image to the right shows what happens when they pour the septic plasma over the cultured cells. What can you see in patients who have died from sepsis who have also had AKI. A systematic review done by Langenberg showed that histological tissue samples from deceased sepsis-associated AKI patients did in fact not show acute tubular necrosis. In fact, they only showed gentle histological changes. Like in this image, on top we have the controls and on the bottom the sepsis-associated AKI samples. The changes we see in these images are only neutrophil infiltrations in the sepsis-associated AKI samples. One has to add, though, that apoptosis is particularly difficult to see. On the other hand, acute tubular necrosis is not seen. So those were the recent advances in knowledge that led up to the paradigm shift. Now moving on to the hypothesis of the pathophysiology. We now believe that the cells adapt to their new harmful environment instead of going into necrosis. DAMPs and PAMPs cause the need for adaptation. Those are acronyms for damage-associated molecular patterns and pathogen-associated molecular patterns. In fact, lipopolysaccharide or endotoxin and cytokines like TNF-alpha, interleukin-6, etc. The DAMPs and PAMPs trigger the cells via toll-like receptors, nod-like receptors, and RIG1-like receptors. The proximal tubule sends the DAMPs and PAMPs first and signals to the distal segments. And the tubular cells then respond with oxidative stress, and this starts an adaptation to a reduced metabolism. In the end, this adaptation can shut down the mitochondria, which leads to a cell cycle arrest. The shutdown of mitochondria in tubular cells starts a shutdown of cellular functions. The cellular functions of the tubular cells is to absorb and secrete particles. And that's why we say that oliguria in sepsis isn't a renal failure, it's a renal success. The cells shut down their mitosis to save energy and to avoid damage to the DNA. This reduces the risk of apoptosis because of damage or energy depletion. If mitochondria are damaged, they are destroyed through autophagocytosis, which is also called mitophagy. The necessary functions like sodium potassium ATPase remain. If you experimentally inhibit mitophagy, that will aggravate tissue damage, and if you stimulate it, it will reduce tissue damage. If there is great oxidative stress, this can still result in cell necrosis and apoptosis. Another pathophysiological phenomena is that peritubular capillaries with continuous flow decrease and capillaries with intermittent flow increase. It is believed that this has to do with INOS, inducible nitric oxide synthetase, which is a catalyst for nitric oxide production. Nitric oxide is a free radical used by the immune system against bacteria. It also dilates blood vessels and causes shunting. It mediates activation of renal caspases, which induce tubular apoptosis. This enzyme has a heterogeneous spread in the tissue, which correlates to the spread of microvascular dysfunction. If you experimentally inhibit INOS, it will reduce AKI both histologically and functionally, but not totally, so there must be other mechanisms. Moving on to the next question. Why is glomerular filtration rate reduced when cardiac output is okay? This is what we learned in school about the control of glomerular filtration rate. There is blood flow coming in through the afferent arteriole, passing through the glomerulus and leaving through the efferent arteriole. This causes an ultrafiltration. If there is vasoconstriction of the afferent arteriole, that increases the resistance and reduces renal blood flow and reduces GFR. If there is a vasoconstriction of the efferent arteriole, the resistance increases, renal blood flow decreases, and the GFR increases. So, what happens in sepsis-associated AKI? One hypothesis involves tubuloglomerular feedback. The macula densa controls glomerular filtration rate depending on the sodium chloride concentration in distal tubuli. Sepsis causes a downregulation of sodium-potassium chloride co-transportation in proximal tubuli, resulting in a rise in sodium chloride concentration in distal tubuli. Macula densa then demands a vasoconstriction in afferent arterioles, which reduces GFR, and paracrine signal to the juxtaglomerular cells reduce renin secretion. So the result of all this is a relative efferent vasodilatation, a dilatation in both afferent and efferent arterioli due mainly to nitric oxide, and there is some relative vasoconstriction in the afferent arterioli, maybe due to the tubuloglomerular feedback. This reduces the hydrostatic pressure in the glomerulus, and in effect there is a loss of GFR caused by efferent vasodilatation. If this is true, can't we give a selective efferent arterial vasoconstrictor? Yes, we can. Angiotensin II is a selective efferent arterial vasoconstrictor. And in a sheep sepsis model, it restored urinary reduction and creatinine clearance. Vasopressin is also an efferent vasoconstrictor, and there have been 4 RCTs, including the VAST study, that showed improved urinary output and creatinine clearance with vasopressin versus norepinephrine. However, the VAST study, which was the largest, didn't really focus on AKI. This was a post hoc analysis. Ongoing is the VANISH study, which is to be completed in the middle of May 2015. What about shunting? Most organs have some form of shunt. The kidney also has a shunt. It was actually described already in 1964 by Karolinska researcher Arne Ljungqvist. He showed that there was a shunt between the afferent arteriole and the vasa recta, so the blood can actually bypass the glomerulus and go straight from the afferent arteriole and go straight into the vasa recta. This could, in fact, explain how renal blood flow can be normal or increased and GFR can be reduced in sepsis-associated AKI. This is an electron microscope image showing the actual anatomical shunt bypassing the glomerulus. Maybe, just maybe, the millions of years of evolution was a success and the shunt has a purpose. We don't know what happens when we give the angiotensin II and the vasopressin. Maybe this closes the shunt and forces blood to pass through the glomerulus and forces DAMPs and PAMPs to pass through the glomerulus. Moving on to the last question, how can we protect the kidneys from acute kidney injury in sepsis? First, just a quick reminder. 40% of patients who come to the ICU do it because of sepsis, and 40 to 50% of the septic patients get acute kidney injury. And we suppose that that is a sepsis-associated AKI, but we don't have a way to tell. The severity of sepsis is related to the incidence of acute kidney injury. So the more severe sepsis, the higher incidence of acute kidney injury. The top graph shows death in ICU and in hospital death, and that it is more dangerous to have sepsis than not to have sepsis, and it's more dangerous to have sepsis-associated AKI than to have a non-sepsis-associated AKI. The bottom graph shows that rifle also correlates to mortality. What can we do to protect our patients from sepsis-associated AKI? Early antibiotics seem to be important. In this study, they clocked the time from hypotension onset to the time when the patients received antibiotics and showed that the longer the patient had to wait for antibiotics, the higher the incidence of AKI. Negative fluid balance seems to be important. Fluid overload appears to be a biomarker of critical illness. In the VAST study, it seemed to be optimal with a positive fluid balance of 3 liters after 12 hours and then negative fluid balance. We know that a fluid overload in acute kidney injury is an independent predictor of mortality and worse renal recovery. And we know that it is a predictor of death when continual renal replacement therapy fails to remove fluid within 3 days. One study showed that early continuous renal replacement therapy to attenuate fluid overload reduced mortality. Avoiding renal congestion is important. The hypothesis is that a high central venous pressure causes back pressure into the kidney, reducing the diastolic perfusion pressure. One study showed that a higher CVP in the first 24 hours of septic shock was linearly associated with increasing risk of new or persistent AKI, and a 5 mm mercury increase in CVP predicted a 2.7-fold odds of a new or persistent AKI. So the diastolic perfusion pressure is a key determinant of renal perfusion. This is consistent with the findings in renal ultrasound, where an increased resistive index suggests that the patient is at risk for AKI. Also, in sepsis-associated AKI, there is hyperpermeability in inflammatory cell adherence that also increases the renal interstitial pressure. Using open lung ventilation is also important. The hypothesis is that a barotrauma releases DAMPs like TNF-alpha, interleukin-1, 6, and 8. And since about a fourth of the cardiac output passes the kidneys, this will affect the kidney. A study showed that in ARDS, lung protective ventilation reduced AKI. What about hemofiltration like CRRT and IHT? Well, it's certainly good for fluid removal, as I spoke about in the previous slides. Maybe it's good to get rid of some DAMPs and PAMPs, but this is expert opinion and probably largely depending on timing. There hasn't been shown any benefit from high dose compared to standard dose. However, those studies did not take into account that also antibiotics are cleared more with a higher dose than the lower dose. And probably most of the patients in the studies had sepsis-associated AKI and were dependent on their antibiotics. When it comes to timing, only one RCT has been performed, and that didn't show any difference in outcome. There are 2 ongoing studies, the START-AKI and the IDEAL-ICU, that will probably give us the answer to that question. Retrospective studies have supported early dialysis. CRRT shows better renal recovery compared to IHT, primarily in vasopressor-dependent patients. And to protect our patients from sepsis-associated AKI, we should also avoid the usual suspects like NSAIDs, ACE inhibitors, hypochloremic acidosis, and using too much nephrotoxic antibiotics. Always measure the concentrations of the drugs if you can. Finally, what does the future hold? Ghrelin reduced sepsis-associated AKI in mice by binding and inhibiting DAMPs. Caspase inhibitor reduced apoptosis and preserved kidney function in mice with sepsis-associated AKI. Interleukin-10 antibodies to inhibit T regulatory cells reduced AKI in sepsis, but not in ischemia and reperfusion. Vagus nerve stimulation decreased the release of pro-inflammatory mediators from the spleen, which reduced AKI. The vagus nerve was stimulated by ultrasound, by the way. I spoke about the RCTs and VAST with selective efferent vasopressors to preserve GFR, and the ongoing RCT VANISH. And I also spoke about the sheep study with the toll-like receptor 4 inhibitor, which was called TAC242. One hopes that there will be a study in humans with that substance. There was a previous study with another TL4 inhibitor called eritoran that was in a trial to reduce death in sepsis, and they did not look at AKI as outcome. There is an ongoing study with levosimendan to reduce AKI. It's called LEOPARDS. Levosimendan is known to cause dilatation of afferent but not efferent arterioles. There has been a study with alkaline phosphatase. It is known to detoxify lipopolysaccharide and degrade extracellular harmful ATP. And that was a small success, but needs to be done in a larger scale. To conclude this talk, there has been a paradigm shift in the view of sepsis-associated AKI. We believe it's about the microcirculation and not the macrocirculation. We believe that the tubular cells adapt, they don't die. And we believe that the targets of therapy should be the DAMPs, the PAMPs, and the inflammation. And if you want to listen to more on this topic, listen and look at this Grand Rounds lecture by Professor Rinaldo Bellomo. It's about 30 minutes and well worth the watch. Thank you.